Hello, I'm Lindsay Wiley. I'm a professor of law and faculty affiliate with our Reproductive Health Law and Policy Center here at UCLA. Here at the center, we've been working to identify strategies for more robust implementation of existing state laws that authorize pharmacists to prescribe hormonal contraception in various forms. As part of our efforts to disseminate our findings and recommendations, we've organized a series of 2 webinars featuring some of the stakeholders we've been working with over the past several months to understand more about challenges and opportunities in this space. In late January, our first webinar focused on strategies for raising awareness of the availability of contraception from pharmacists, both over-the-counter and pharmacist-prescribed options. Today, we're going to be focusing on a major area of study for our project, Medicaid and private insurance reimbursement for pharmacists when they provide hormonal contraception under state laws expanding their scope of practice. So I'll start our discussion with just some very brief introductions of our 4 esteemed panelists. We're going to format this discussion and interact as an interactive, moderated kind of Q&A. So as we're talking, feel free to use the Q&A feature in Zoom's webinar to submit questions that you may have, and I can incorporate those into the discussion as we go. So I'll begin with Dr. Marlene Battle, who is a pharmacist and director of education at the Arkansas Pharmacists Association. Dr. Nikki Hilliard is Director of Professional Affairs at the Arkansas Pharmacists Association. They'll be talking about their work in partnership with several stakeholders to implement Arkansas's expanded scope of practice for pharmacist-prescribed contraception. We're also joined by Dr. Ryan Pistorici, who is Assistant Chief Pharmacy Officer at the Washington State Healthcare Authority, where he provides clinical support to the state's Medicaid program known as Apple Health, and Andrea Estes, who is Sexual and Reproductive Health Programs Innovation Manager with the Washington State Healthcare Authority. They'll be talking about sharing their perspectives on implementation in Washington State. We've also got more information about the panelists and links to their bios in the chat so that you can learn more about their backgrounds. So as I said, we're going to be having a moderated discussion with our panelists today, and I'll be monitoring the Q&A feature. If you have questions that you want to present as we go along, I'll incorporate those into the discussion if we have time when they connect to the topics that we're discussing. We'll also have our UCLA events staff posting some links in the chat, as well as some of the panelists may do so as well to direct you to some of the resources for further exploration of the topics that we're discussing. So I'm going to begin with a question for Nikki Hilliard and Marlene Battle. Can you start us off with your perspective from the Arkansas Pharmacists Association by sharing a little about the role of pharmacists in prescribing contraception? What's at stake here? What are some of the success stories?
Well, I'll kick us off, Lindsay. First off, I just want to say good afternoon to everyone. Thank you for joining us today, and thank you for the opportunity to be here. We're both excited about this opportunity. But there was a great need for pharmacists to be involved in increasing access to contraception services in our state. We looked at the statistics. So over half of the 75 counties in our state are considered maternal health deserts. At one point in time, and I don't know exactly if this is current or not, but when we began this work, we were ranked number 1 in maternal mortality, the state of Arkansas. We were ranked number 4 in infant mortality and also number 1 in teen pregnancy. So again, there was a great need for these services. Legislation was passed in 2021. It was the Arkansas Act 408 of 2021, and I believe that may be in the chat or will be placed in the chat. But that is a legislation that allows us as pharmacists here to be able to prescribe oral contraceptives. So as part of that legislation, we had to develop a protocol training, and Nikki and I had a front seat, a venture with that, and we were part of the team that helped to develop this protocol. It had to be approved by a state board of pharmacy as well as our medical board, and it's approved for 1 hour of CE. To date, we've had over 1,000 pharmacists to be trained to be able to give or prescribe oral contraceptives in our state. And we made it happen through the training is online. Also, we host regional meetings every year where we travel the state. We host about anywhere from 8 to 10 meetings. So that was a part of our efforts as well, as that we did the training at those regional meetings, where we probably have close to over 400 or 500 pharmacists that attend our regional meetings. And so we were able to get some of them trained there as well. Also, it helped that Walmart came on board to be able to provide their services within their stores that's located throughout our state. So that helped greatly increase access to contraception services as well. We have independent pharmacies that are also offering the service. We also obtained payer support from Arkansas Blue Cross Blue Shield. Nikki would tell us more about that in details later. We also had a beta testing group, probably of about 15 or so pharmacists across the state who willingly volunteered their time to be able to help test and make sure that everything was going okay with medical billing. Because this was a first for us, being medical, doing the medical billing pathway as pharmacists. And then one of our big successes that we like to, tell people about or share is that we obtained a generous philanthropic donor that assisted greatly with training and public awareness. So that helped us out a lot. And then lastly, we had champion pharmacists that were also very instrumental in helping, this become a success in our state with pharmacists prescribing oral contraceptives.
Thank you for that. And that's a great overview of a lot of the topics that we'll explore in more detail in the discussion as we go along. Nikki, do you have anything you want to add about the overview?
Well, I did want to mention that, we kind of forced the training on pharmacists when they came to these meetings. And so just because we had 1,000 that we were obtained, that doesn't mean that all 1,000 are providing this service, but they could. They checked the box that said that they did the protocol training. We've had a number of, and I'll mention a little bit later, we did a number of different trainings in medical billing and advanced training for oral contraceptives, both online. And so just to say that we trained 1,000 doesn't mean they're all doing it. So the uptake is, there's a learning curve. So we're trying to get through that. And some of them are early adopters and some are still lagging behind. So.
Definitely one of the themes of our findings has been that there are so many different gates that need to be open, so many different kind of steps that all need to be implemented. And there are challenges around sort of which comes first. But training that many pharmacists in your state is definitely an important step. Andrea and Ryan, is there anything that you can add in terms of what's at stake, why this is a topic that matters in terms of access, from your perspective at the Washington State Healthcare Authority?
Sure, I'll jump in, and then Ryan can add anything in. Hi, thanks for attending. Andrea Estes. I joined the Healthcare Authority just a couple of years ago, and really what was kind of coming into our purview was the approval of OPIL. And so the work that we've been doing within HCA divisions and across state agencies, and even external to our state agencies, has really been about understanding the context of the entire kind of pharmacy network as an ecosystem that could enable better access to all methods of contraception, OTC or otherwise. And so although Washington's Healthcare Authority that oversees Medicaid as well as public and employee benefits, or school and public employee benefits, we have had a coverage option for quite some time, but we've learned a lot. We've learned a lot on what the consumer may or may not be aware of. We've learned a lot on the limitations in billing. And so what we've really worked toward doing is trying to better understand our role in bringing clarity to the provider community, and bringing greater awareness to the consumer community around what is available to them, what are their rights. And we'll talk a lot more about that later. Ryan?
I also just want
So
to
I'm
jump
Ryan
in and just
Distressy, Assistant Chief Pharmacy Officer. And so our agency, we handle reimbursement. So we're not actually out there, providing services or working directly with the pharmacist to promote that. That's really, for our state pharmacy association. And so kind of like Arkansas has mentioned, our state association also has trainings and programs. And I think over the last few years, since 2015, they've really expanded the network statewide to provide the service. I think really the two challenges that we're seeing are people aware that these services are available at their pharmacies, because typically they still only use these pharmacies for their prescription drug services. They are not aware of some of the other things that these pharmacies do, such as the hormonal contraceptive, naloxone, TB testing, travel consult. So it's really expanded. And I think one of the challenges is that people, they go to the pharmacy, they aren't aware of these things until they're there, and they may not necessarily need them at that time. I think really that communication, understanding, and availability is, one of the hurdles. The other big hurdle that you'll hear us talk about is unfortunately around provider status for pharmacists in Medicare and Medicaid. So unfortunately, the way the laws are written, these pharmacists that are doing these types of services can't get reimbursed by our Medicaid programs because they are not recognized as provider status. And so that is something that is being taken up by a lot of different pharmacy advocacy organizations. I know that there are a House and Senate bill in Congress that would amend those sections of the US code to add in pharmacists under the definition of healthcare services, which would then open up the door for us to be able to use federal match in order to pay pharmacists for doing the services that a physician or other healthcare provider is currently doing. And I think, once we address those two, major hurdles, then I think there will really be a watershed moment in which a lot of the community can begin using these pharmacists for these and other services.
And I'll add on to that, Lindsay, just a little bit in terms of the family planning landscape. And that's really where where my focus is in my role with Washington. And we have a major shifting landscape to contend with. So there is a huge opportunity in seeing the pharmacies and pharmacists as additional players, significant players across Washington state, including those within a rural community where we have more limited access.
I just want to highlight a couple of things that we heard just now and maybe ask Marlene and Nikki if this is resonating with their experience as well. I really appreciated, Andrea, that you mentioned the O-pill over-the-counter option. And when we first started this project, that hadn't happened yet. And we had a moment to check in and sort of think about what is the role of pharmacist-prescribed contraception in an environment where there's an over-the-counter option, and decided that it was really a moment to leverage the opportunity of increased awareness among customers coming to retail pharmacies, that if they know about an over-the-counter option, that may or may not, that one over-the-counter option may or may not be the right option for them. And so in our previous webinar, and this is available through YouTube, Kelsey can maybe put a link in the chat. Our previous webinar really discussed taking those two topics and bringing them together, the over-the-counter option and the prescribed option, so that when folks are aware of pharmacies as a source for their hormonal contraception, they may come because they hear about the over-the-counter option, but then we're able to connect them with what they need, even if that's not the right fit for them. The other thing I heard from Ryan was the idea that this isn't, from the pharmacist perspective, and from the regulatory perspective, this isn't only about hormonal contraception access. There's also expanded scope of practice for pharmacists to provide other services. Naloxone, the pharmacies played a really important role in access there, as well as vaccinations, tobacco, smoking cessation, various other services that we think of as kind of clinical care coming from pharmacists as service providers. Marlene and Nikki, do you want to say a little about how you see those connections before we move on to the next topic?
Yeah, I think, as Ryan said, there is a big disconnect with patients not understanding the services that are available. One of the things that we're doing is putting signage in at the OTC counter where the contraception is available to say, check with your pharmacist for, for consultations for other services for oral contraceptives or just a contraception consult, because it may be, IUDs or what the patient should be on, and we can refer them to someone that could take care of that for them. But yes, I think it's important. But for us, we decided that it was important to build the network first. I can't say go to your pharmacist, because if they're not doing it, then they'd be kind of lost. So first thing that we did was make sure we had an adequate sort of network of pharmacies that were providing the service in the state. And then we've reached out with social media, and we're trying to do some television type ads or spots, where we could reach the public. But for us, the first thing to do is to build the network. So that's where now we're at the point where we can expand.
That makes a lot of sense. One of the themes we heard was you've got to ensure sort of steady availability and reliability of the service before encouraging consumers to come take advantage of it. Because if they have the experience of, oh yeah, I heard this message that I could come, and then they weren't able to get the services that they need in that moment of their greatest convenience, it may, deter them from seeking services that way in the future.
There is a website called birthcontrolpharmacies.com. And, they have a listing of all across the United States of where pharmacists are providing this service, which is great, because I had a pharmacy that said someone gave them a call and they drove 2 hours, to come to their pharmacy because they didn't know that it was available anywhere between that space. And so that's how she got the consult, was through online Google searching, I assume. So yes, people are looking for this service, and unfortunately, it may be in their community, but they may not be aware of it. So
really important points there too. And maybe Kelsey can add that to the webinar chat for everyone soon. birthcontrolpharmacies.com, I think, or .org, I forget which. Marlene, anything to add from your perspective?
No, I think it's been, well covered. I know we were talking about the OPIL. I know the OPIL is in our state. From what I've seen, pharmacies that are near where I live, I've seen those, close to the pharmacy counters. And I've seen them on clearance section as well, which is fine, affordable for patients. But I think I agree with Nikki. Just our focus had been on building our network, and now it's time for us to, expand in our state and get more pharmacists on board with actually providing the services.
Thank you for that. Can I go back to Ryan and Andrea and just make sure that we've had a little bit more of a comprehensive discussion about the timeline of implementation in Washington, and then I'm going to come back to the Arkansas case study and do a deeper dive in the stakeholders that they've worked with, especially Blue Cross Blue Shield.
Yeah. So the timeline, pharmacists have been able to have collaborative drug practice agreements in the state, since the 80s. And so it's been a while that we've had the ability where a pharmacist could partner with a prescriber and be able to do services under that license. I think really the challenge is that pharmacists weren't getting paid for doing that work. And if they aren't getting paid, there really is no incentive for them to do that work. So it wasn't until 2015 when we had a bill that required parity payment. That was, Senate Bill 5557 in 2015 that required health plans in the state to pay a pharmacist at parity. So I think since then there has been a wider adoption for it because health plans have had to enroll pharmacists as providers. They've had to have an adequate number of pharmacists with these services, and it required these plans, to pay for them. Although it didn't impact our public employees and school employees programs directly, we voluntarily adopted it. It's with our Medicaid program that we weren't able to do that, mainly because of the issue that I had mentioned with provider status. And if we were to choose to cover it, it would have to be with state-only dollars. And that would have been a pretty significant ask for the state, on top of all of the other budget issues going on. So unfortunately for us, we don't have that availability under our Medicaid program unless the MCOs are choosing to cover that as their own service.
And so the MCOs are not covered by the same sort of private payers, but they may be choosing to do so, especially if they're starting to cover it for the other plans that they offer, right? Maybe you see some Medicaid MCOs offering that within their Medicaid plans, if they're also starting to offer it in other products that they're
Right,
offering.
because it would create a two-tiered system within them. So they would have to have a system in place in which they would have to identify, this provider submitted this claim, and then let them know after the fact that, hey, this was not covered. I think instead of having more work on their end for the MCOs, they may choose to have it be easier and not have those issues in which a pharmacy sees someone with, a United card and knows, well, are you Medicaid or not? Well, I can't provide the service if you're Medicaid, and creating kind of that tension in the community. So I believe that they are, choosing to do that within their system, similar to with our public employees plan. We're under Regents, and so for their book of business, they have pharmacists enrolled. We did not want to tell them, hey, we can't have that same network for our public employees program. We don't want to create this two-tiered system. So please, have them be enrolled and eligible for reimbursement for our public employees and school employees programs.
I'll just comment that fragmentation is just always a challenge with implementing any kind of new law promoting access to healthcare. Just the idea that any given payer, as you mentioned, United Healthcare has multiple plans that are regulated and implemented and administered differently depending on the population they're serving. Definitely a common theme when we're talking about implementing these kinds of reforms. If I can go back to the Arkansas team and ask you if you could share a little more. We were really impressed by what we learned from you in our interviews and in our convening about your work with Blue Cross Blue Shield, specifically to get them on board in the partnership that you've done there. In figuring out how to implement reimbursement to ensure that pharmacists can bill, and just to clarify for our audience, we're talking about billing for the time that pharmacists spend on, conducting consultation, on assessing patients, and not just billing for the medication, not just reimbursing for the medication itself that's dispensed. I know you've also, you mentioned your training programs, and I know those training programs have also included some aspects of medical billing. You've already mentioned that's a new thing for pharmacists to navigate. I'd love for you to just say a good bit more in detail about those partnerships, about how you've overcome these challenges. It's something that a lot of other states, I think, can learn from.
Well, yes, a big thank you to Blue Cross Blue Shield of Arkansas for really stepping up into this space. We had a conversation with them, I guess, in 2022, and said we had an ask, to pay for pharmacist services, and we had champions within Blue Cross Blue Shield to take that. Denise Clayton, who's a pharmacist, and Dr. Mark Jansen, who's the medical director, were very supportive, and they really took the ball and ran with that, not just for oral contraceptives, but naloxone, point of care testing, HIV testing, smoking cessation, naloxone. All of those things are paid, but all of the ones that they're paying for were legislated, that were sort of demanded from the legislature to provide those services, or that they were needed. And so they took it, and it was not an easy feat, because they didn't really have a payment structure for pharmacists. We know that we're not in the Social Security Act, so they had to kind of set up a new system. But they opted to pay pharmacists just like they do every other healthcare provider. So that was good. They didn't carve out and just say, okay, we're going to pay you this special way through a pharmacy system. And in fact, they did have some PBMs and some systems said, oh, we'll enter this space, we'll help you pay. And they didn't want PBMs in that space, and we're thankful for that. But anyway, but pharmacists had to learn the medical billing pathways, and so that is a challenge. So it included credentialing, and I think we'll talk to that specifically in more detail. And one of the interesting things is they had to develop payment codes for us. We know that there's, a huge book of payment codes that are out there for billing, but for pharmacy services, they said, okay, looking at it and with compliance with CMS requirements, and pharmacists aren't allowed to diagnose by practice right now in most states. So they had to come up with billing codes that didn't involve a diagnosis. So they don't want us just opening up to anything that's in the medical billing book. They specifically gave us which codes to use, and then they would pay us for the time encountered. And so that's one of the things that was very helpful, is working through them very closely. And we had monthly meetings with them for 2 years, working through this. And we're still an ongoing effort because they really want to see this implemented, and they've been doing a great job in keeping our feet to the fire. One of the things they pay us, just like other healthcare providers, that they pay us at the same rate for other non-physician providers, such as nurse practitioners and PAs. They pay us at about 75% of the physician rate for payment. And that's pretty standard. It's what the others are getting paid for as well. So we had to use the same platform, we had to use their billing platform. And so they use Availity now, and that's a learning curve. So learning how to do medical billing when pharmacists aren't used to it has taken a lot of effort. And they can bill. Blue Cross uses the Availity platform for their claims processing, so you have to learn that system. But you can use third-party vendors that work through their pharmacy software. Things like the Pioneers, Red Sail, TransactRx. There's a number of different ones that work through that, and they charge a fee to use, and they kind of, it's sort of like an easy button. They kind of do a lot of that for you, which is helpful. It's not required. You can use the other system that doesn't require the fee, and so sometimes it just depends on the how many claims you want to, if it's worth it or not. But that's one of the systems that are out there. And sometimes they've given us good deals through the association to get people on board and gotten rid of the fees as for a period of time. Now, one thing also is it's important to have those payers on board. And in Arkansas, we only have the one payer, and so we have payer conferences coming up trying to get more payers, especially Medicaid, on board as well. We approached the largest payer in the state first because we wanted to kind of get a system and then hopefully the others that will come on will use the same sort of system and not reinvent 5 different wheels to go through. But I wanted to make a point in that they can also charge a cash-based price. And it's, because if you don't have other payers, then of course the patient can pay for the service themselves. And so we wanted to make sure pharmacists, there's nothing wrong with charging a cash price. You want to have some parity, between what you're charging the insurance company and what you're offering for that service. But they do see that you can do a cash-based discount, and because not every payer could pay. Some women may not be able to pay, and so sometimes the pharmacists are allowed to kind of work with them on their discretion. One of the things we've done is also have a number of training programs for medical billing. We did medical billing boot camps where we would come and sit down and go through the codes, how to do the billing, how to do Availity. We'd invite the pharmacists and their staff. It's really important to have the technicians or a billing technician or somebody besides the pharmacist to do that. So it really works best when you have a technician maybe do the intake and then hand it off to the pharmacist to do the consult, and then let the technician do the billing platform, and not have the pharmacist do the whole account, all of that, because that's too time consuming, and you want someone else to help you with that. So we invited, the technicians to come as well. And so we had a number of those where we would hold them on site. But then we figured out that maybe it'd be interesting to do field trips where you actually go to a pharmacy where they're doing those encounters, and we'd have we'd watch, see how are they doing it, what kind of room, what are they just see it in action. And then we'd sit down and go through some of the information with the participants as well. And so we had a number of those as well. That worked out well. And then the next phase we're going to is one-on-one coaching. And we specifically have a number of pharmacies where we're going to identify as maternal health deserts. And we want to specifically recruit people in those areas and coach them one-on-one to whatever it takes to get them to help get them to offer those services. So it's time intensive, but we think that it's one of the best ways to get it done. Recently, we've had the UAMS College Pharmacy has a community pharmacy residency program, and they've done a survey of our pharmacists and asked them, how's it going? What are the barriers? What's your perspective on this? And they did a survey, and we'll put the link to the survey results that will be presented. Megan Smith is the director of the residency program, and she's been extremely helpful. And Natalie Novak is the resident that is doing the survey as her project, and she will be presenting that at APHA. But one of the interesting is it highlighted the need for additional training. Pharmacists, about over half of them said they're kind of uncomfortable selecting the products to use. Which one? When we have a test and treat protocol, it's very prescriptive on, okay, you use this antibiotic or this antiviral, and they don't really have much of a decision to make, as opposed to there's hundreds of different choices for birth control. So we're going to do additional training. So that was one of the needs that was identified. And then just the kind of the other barriers that they have, she identified is the workflow and seeing how it works, and do they need to have an appointment-based model? We always talk about it's one of the things you can just walk in, but it is nice when they can schedule it and have an appointment set up. Some needs for, they have inadequate staffing, the time constraints that are involved, and reimbursement issues. If I know Blue Cross Blue Shield is paying, but the number of people don't have a payment, and they're not used to that. And so pharmacists aren't used to asking for payment for clinical services. And one of the other things is, they have to have the private consultation areas. And so a number have those, but they're working through some of the barriers to make sure that they have good patient care. But getting a payer on board was critical process for pharmacists in general across the nation. And I know Blue Cross Blue Shield of Arkansas is wanting to help other Blue Cross in other states. And so they have willingly volunteered a lot of their time and effort to address and help other states as well.
I really appreciate that. You've done such a beautiful job of laying out all the challenges that we're mapping, but also some successes that can be shared with other states and other advocates. Excuse me. I wonder if you could say we have some questions in the chat following up from some of your comments, so I'm going to highlight those in a moment. First, though, I wonder if you could just say a little more to lay out the enrollment process and then the billing process as two distinct components of the challenges around reimbursement. So could you start by saying just a little more about the enrollment process and how you've approached that? It looks like Marlene might be ready to jump in here.
Yeah, I can talk a little bit about the enrollment or credentialing process. So our process is basically the same. We have the same requirements as other healthcare professionals, where we have to show, certain documentation like about education, license, and et cetera. Both the pharmacy and the pharmacist must be approved. So the pharmacy and the pharmacist both have to be credentialed. Nikki stated about a privacy area. That is a requirement, that you do have a HIPAA compliant counseling area. It just can't be off to the side. It actually has to be a set privacy space, whether that's another room, or we've had pharmacies implement enclosures, spaces in their pharmacy, to meet that requirement. And Blue Cross Blue Shield will conduct a site visit to make sure that everything is in place, as far as your counseling area, paperwork, and all of that before you can become credentialed with them. Now, I will say about Blue Cross Blue Shield, they have made this as easy for us to help streamline the process as much as they could on their end, because they have what are called network development representatives, and they have them located across the state, where they're assigned a specific region. And so that's really where the credentialing process begins, is with them, is that you would reach out to your specific NDR, is what we refer to, and they help you with the credentialing process from beginning to end. And I will say that it's not an overnight process. It does takes time because it's quite a bit of paperwork involved, and then with the site visit. So you're looking at anywhere from maybe 30 to 60 days, to be able to complete that process.
And just to clarify for our attendees, because this topic involves so many different areas of expertise, so any given attendee might know a lot about one area but not about others. This credentialing or enrollment process, this is something, in addition to the license that a pharmacist has with the state, or that the pharmacy has. It's a process with each payer, right? So Blue Cross Blue
Right.
Shield asking for this documentation, asking to see that the service is going to be provided in a safe and effective way at each site and by each pharmacist. That's right.
Yes,
And
that's
one of
correct.
the challenges we identified was that in an environment where there are multiple payers, that might be a process that the pharmacist and pharmacy has to go through with each of those payers. So a
Yes.
lot of challenges. It sounds like Blue Cross Blue Shield has been very proactive and very cooperative about helping to support pharmacists in implementing the enrollment, the credentialing side. And then once they're credentialed, they then have to be able to navigate the billing system. So they're credentialed, so it means they can submit billing, but then they also have to know how to do that. You've said a little bit about the importance of technicians and supporting that. You've mentioned that you've done the training on site. Do you want to say a little more about sort of what have been the most important movers on the billing side, in your experience?
I don't know that I know the most important part of it. One of the things is successes. And I would say, having a demand from the public is almost that, pharmacists are really good about jumping over hoops to try to provide. If somebody asks for it to help, they will help them. The demand from the public is one of the things that gets them moving the most. Sometimes when you find somebody that comes in and says, "Hey, I need some help," and then they'll try to do what they can to help them. But we do have a notebook in place that when we provide the boot camps, or they can just get the notebook online. But basically, it's got all the billing codes. It's got all the forms that they need for intake. It's got the referrals. They have to notify their physician that they are getting like birth control. And so all the forms that they need are available to them. And so there's a notebook for each pharmacy, hopefully, that they can help provide those services, and try to, they don't have to come up with it on their own.
And I'll just add that any opportunity that we have to try to be proactive and keeping medical billing at the forefront of their heads, and the services that they can prescribe through the medical billing pathway, we take those opportunities. We stated some of the trainings that we've done. In addition to those, we have our annual convention. So we make sure we have, a main session to talk about medical billing or some of the services that are offered. We do specific breakout sessions, to give more one-on-one attention to medical billing. So I think that's been important for us on our end also, in helping to push out the services and helping push the pharmacists. Sometimes you just need a little push to get out there in the water, and then you can maneuver, tread, or swim a little bit. So that's something we focus on as well.
We do have a very strong CPSN, which is the Community Pharmacy Enhanced Services Network. And it's a group of pharmacies that are kind of our, early adopters.
I think Nikki's frozen for me and probably for others. I see heads nodding. I heard her mentioning a network of early adopter pharmacy is really important resource to keep in mind. And we'll see, maybe Nikki can try going camera off in a moment. While we wait for that, I'd love to bring Washington back into the discussion to address how some of these enrollment and credentialing and billing codes have worked in your perspective.
Can you hear me now?
Yes. Why don't you wrap up what you were saying, and then we'll also bring Washington back into the conversation. I think we lost you when you started mentioning the network of early adopter pharmacies.
Yes, Ian.
Well, I was saying that CPSN has been a good partner on this. They had 170 different pharmacies in the state. And so these are people that are providing advanced services. And so you don't just go and learn to do medical billing just for oral contraceptives because, it's not enough business there right now. So when they do test and treat and naloxone and all these different, if you advertise a variety of different services, then it kind of helps then you can invest the time to do medical billing. So.
Yeah, that's actually a great moment to bring in one of the questions from the chat, actually. With respect to those other services, is credentialing something that applies to any of the services that the pharmacist then provides, or does it have to be handled service by service? So hormonal contraception versus vaccination, once they're credentialed, are they credentialed for all of those services?
Yeah, it just means that they're a approved provider within the network for the payer. So
the services that are within their scope of practice. It's not
right. You can't just say, "Oh, I'm a provider. I'm going to start billing and getting paid for it." They have to make sure you're who you say you are, and that you do have really do have a location and all those different things. It's just part of their system, not just for us, but for all their providers. So.
That's really helpful to clarify. Thank you. I'm going to hand it back over to Ryan and Andrea and ask if you could share a little bit about your experience with billing codes with credentialing as well, if that's something you can speak to.
Yeah, so the way that we have things set out for our Apple Health program is through our billing guides. So we have a lot of different billing guides intended for different services, different audiences. So I can speak a bit to the prescription drug billing guide, and then Andrea for the family planning one. But what we like to do is, to have it be in charts, so that you can go down and kind of see, here are the services, here are the codes, here's how you enter the codes, because between us and different payers, they may have different requirements for submitting different information in different fields. And so in our billing guide, for example, if you go down to the emergency contraception, there will be information around what diagnosis code and what procedure code will need to be submitted in order for that claim to be accepted and for you to be reimbursed. You have different product ID codes that need to be entered in different fields. What NPI to use, what NDCs to use. And so we just try to make that as apparent as we can in the billing guides for the most common situations. So for the pharmacy guide, this is really where the pharmacists are likely to go to understand, how they have their services covered. And then for family planning, I'll let Andrea take that.
Yeah, I mean it's sort of analogous, but the for family planning in terms of the billing guide and those details, I think a lot of that generally sort of focuses on kind of the clinic setting though. So about a year and a half ago, we engaged providers in listening sessions as well as a survey to try to better understand what the provider's perspective was on around this billing, prescribing and dispensing. And really, I think what my biggest takeaway was we probably have some answers in these documents and online, and they need not to be elusive. And so it is kind of holding the provider's experience, their time constraints, the intensity of every day in at the center, and to try to figure out what our best mechanisms were to better get that information into the hands of the pharmacist, whether they be technicians or pharmacists themselves. And so we did learn a lot about like the communications tools to be able to disseminate this information from the healthcare authority to the provider community. So, for example, like the association colleagues we have on the phone today, we've gotten closer to our Washington State Pharmacy Association, who has a really robust professional development network. And so we collaborate with them. For example, for family planning only, I developed a continuing education credit, and we've done a couple of presentations at some of their broader network meetings. And that's, to for folks to better understand what the rights are of clients in Washington State for family planning, and to see themselves, their businesses, in playing a role in that space. And it's been really interesting to get a sense of what people know or what they don't know that could be afforded to our clients and our neighbors in Washington State. So I would say that the continuing education credit has been a useful mechanism, both beneficial to providers and the expectations that they have professionally, as well as for us to keep, what reproductive or contraceptive access should mean to folks in Washington. Our billing guides, I mean, bless them, but they're dense, and so when we do updates, which we do quarterly, there are often many. And so what we've also tried to lean into is pulling out, as we being, and like also family planning in collaboration with my pharmacy colleagues, like pulling out what updates are happening that are specific to family planning, for example, and then pushing those out in like what is effectively a newsletter, or what we call a bulletin through GovDelivery. So instead of just saying more generically, we've updated the billing guide. It is, here's an update to the use and the utilization of the NPI code as it relates to over-the-counter contraception, for example. So those are some examples that sort of build on, I think, what Ryan was talking about in terms of how the healthcare authority kind of holds their billing information, and then how we intend to get it out more effectively into the provider and the provider's hands. More on the consumers later.
Yeah, I really appreciate that, and just the complexity of these systems really
Yes.
comes through, including for pharmacists who are under a lot of time pressure, or who are under experiencing burnout even potentially in their work. So it's a complex system to navigate for the pharmacies and the pharmacists. I have a few follow-up questions, one from the chat, which I'd invite everyone to weigh in on, which is the question about the use of existing CPT codes versus the development of new codes. I know, Andrea, you've mentioned the development of dummy codes for the OTC contraception in some instances. I wonder if anyone of our panelists could speak to this question of using existing codes versus modification or development of new codes.
Well, I don't know that I would advocate new codes. There's plenty of codes out there. But like I said, we kind of handpicked the ones that would work for pharmacists in their practice. In Arkansas, we did pass legislation that said pharmacists can prescribe OTC medications so that it would be covered by insurance or things like that. So if a woman would have to pay over the counter out of their pocket, but if they wanted to prescribe Opill, then it would be covered maybe by their insurance. And so the legislation says that we can do over-the-counter prescribing. And so in that way, it's one way to navigate that.
Right, especially because these services that, or rather the hormonal contraception it comes with no out-of-pocket costs if it's prescribed and covered by the plan. But if it's over the counter, but you're purchasing it, just the way that you purchase anything over the counter, that can come with some costs. Andrea.
Yeah, and I want to preface that I am not clinical, so my clinical colleagues can also correct me if I'm misinterpret anything or misspeak. But so the DEMI code, it's not a CPT code, it's a NPI. And I believe it's been around for quite some time. In fact, when we were doing one of the presentations for the continuing education credit, somebody called it what was it, like the doctor's NPI? I don't know. It was very generic, but it was a code to be able to, that was applied to be able to push through an OTC claim, because this is about the tech system at the pharmacy level, and that the technology systems were built to process prescriptions. So there was confusion on behalf of the tech, not the technician, the technology, to process these claims, and that was the function of this dummy code. But since then, our kind of messaging around that and our engagement with UCLA, the expectations on the use of that have shifted. And so Ryan can jump in, but we have updated our own guidance to no longer use the dummy code, and it would more than likely be a pharmacist NPI.
Yep, and I can confirm that. So, as of our October billing guide, we actually have this in the top section of what changed. So, at the top of our billing guides, we try to have a summary table of say, well, what's different than our July, provider billing code or April billing code, and right at the very top, it talks about removing that NPI and instructing the submitter to use the prescriber, pharmacy, or pharmacist NPI number. And this was really to align with guidance from CMS that we had gotten last year. So in accordance with that guidance, we updated our billing guide. And so that dummy code, even though it was useful in the past, has changed. And so, I always recommend people to look at our most up-to-date provider guide because things always change. There were some that went into effect on March 1st. And so, we are always updating this to make sure that our systems are configured properly for the providers to submit the codes and get reimbursed for the services appropriately.
And I'll piggyback on that. So just to sort of reinforce what when this update was made, we pushed it out in a Gov delivery. We sent that Gov delivery to the Washington State Pharmacy Association. I believe that they disseminated it to all of their professional development groups. And our offer is to, reach back out if there are questions, bring us in if you need us to come talk about it more explicitly. And so that's the kind of relational shift that's been very intentional for us. And we hope that it makes kind of these changes in real time more accessible and understandable. We also have had shifted relationships with, I think effectively advocate communities, right? And so some of those have been pharmacists who are working in the field, who are community pharmacists. And they've been able to give us perspective on what's working and what's not, or where there still might be hiccups. And so I believe it was a part of the same sort of dummy code discussion that there was variation by kind of pharmacy business model. So like if it was a corporate entity versus like a community pharmacy, and whether or not those internal policies allowed for the billing to go forward, say with OTC. And so what was dropped in the chat here, for example, is an FAQ that we published. And we've learned that the pharmacists and the pharmacies who maybe are having even business level challenges with their own sort of corporate or business policies, that they're able to use that FAQ to say, here's the expectation and standard within the Medicaid policy frame.
And one of the things that there's like thousands of CPT codes, but right now, and we only have like 10 that we're billing. And so you can it's not that complex right now, and we don't get to pick all the different things that we can bill for. And so we keep it simple, say, here's the code, you build the code and you build the time. And it's just the navigating the system and learning the new medical billing is new to a new learning curve, but it's not that complex.
That's really helpful. And in response to one of the questions that I see in the chat, it sounds like the pharmacist associations in both of your states are playing an important role in helping to identify, a smaller subset of codes that are most effectively used by pharmacists, and rather than having them, navigate the entire enormous scope of potential codes. Is that right? That the associations are playing an important role there?
That's correct. I mean, we started with a few, and then we added on HIV, and so then we added on new billing codes for that. So, but we just say, okay, these are the only ones that Blue Cross is going to pay for. Hopefully, we'll be able to add on more and more payers as we go. But we try to keep it simple, and they don't do that for other providers. They don't say you can only bill these codes, but and for us it helps, because you don't get lost in the coding part.
And I can confirm for our state pharmacy association, they do have a section dedicated to helping pharmacists understand how to bill between the different private, commercial health plans, how to set up these collaborative practice agreements. So just really giving them the knowledge for here is how you set up this business and can make it a successful business where you actually get paid adequately, for your services. So I can't speak from personal experience because I haven't taken those courses, but I do know that those are options available through the Washington State Pharmacy Association.
Thank you for that, Ryan. I want to ask another question from the chat that might move us in a slightly different direction. So before I do, I just want to see if there's anything else on the kind of nuts and bolts. This has been a really helpful conversation, I think, for our attendees, but the nuts and bolts of billing that anyone wants to add before we move back to a little bit of a broader frame. It's really complicated, I think, is the main takeaway. And yet, the pharmacist associations are playing such an important role working directly with the payers. A proactive payer like Arkansas Blue Cross Blue Shield can make a big difference. Apple Health as well, sort of working with the pharmacies, with the pharmacists to navigate the complexities of the system, all in service of access, of improving access, particularly in rural areas, particularly for underserved populations. So really great to get into the nuts and bolts there. I want to next ask one of the questions from the chat, which will take us into our last topic for the webinar, which is the different sort of stakeholders, the different roles that are played. A really great question in the chat about whether Apple Health plays a role in educating consumers, educating patients, enrollees about their options that are covered for obtaining pharmacist-prescribed contraception, or going, with a pharmacy first approach.
And I apologize, but I really thought this was scheduled until 1. And it's a call with CMS, and so I've got to go. So thank you for Ryan for picking up any slack. The consumer messaging is important from the family planning lens. What we also heard from those pharmacist listening sessions was really that they didn't believe, like it was when we showed up to talk about billing, one of the issues was people don't know that they don't go to the retail counter. They have to come to the pharmacy counter. And even when they do, consumers don't know the array of products that are available to them. So again, like we were wanting to also talk in from the lens of client choice, not just about this really came from the over-the-counter options. And so, of course, though, it would be inclusive of both. So we have begun doing more social media from the lens of family planning. We are considering, we have learned from the Women and Infants and Children's WIC program that they have a consumer app that they have used that has an exceptionally high utilization by consumers to know what's available to them and what could be, a replicated model for contraceptive methods. And so really trying to put the information into consumers' hands of what's available under the Medicaid benefit. Thank you so much for everyone's time. I'm so sorry.
No, it's no problem at all. Good luck with your CMS meeting. We definitely don't want to stand in the way of that.
Bye.
Ryan,
Lindsay,
yes.
No, go ahead.
Oh, I was going to say, Ryan, can you pick up, or Marlene, did you have something you wanted to say in follow up to that?
Well, no, he can go. Brian can go ahead. I was just gonna say, I know you specifically asked about the Apple Eye Health, but I was just gonna go along the lines of Arkansas Blue Cross Blue Shield provides. I believe it's a quarterly magazine. Don't quote me on that. But they have a magazine that they can send out to their patients, and I know they've been big advocates and have let their patients know, their members know, that pharmacists can prescribe oral contraceptive services. So that's helped, as well as getting the word out to those members.
Actually, I'll stay with you for a moment, Marlene and Nikki, because one of the follow-up questions I wanted to ask was going back to something you said earlier about the signage in the pharmacy on the shelf where the pill is available, directing you to alternative options. Is that something that you've worked directly with the retail pharmacies to implement? How did that come about?
Well, one, was in a Walmart pharmacy and I saw that they had the signage on their shelves. And so, and then with our philanthropy dollars, we made a desktop flyers that go at the pharmacy counter to say, ask me about birth control. We have signage at the over the counter section. They've had bag stuffers that let them know, like I said, and then Blue Cross has actually, sent things out to their members. The other thing we've done is they've given us, like which payers, when I say Blue Cross pays, they do have, different clients, and so it may not be across the board, but they've given us the codes. I mean, that which groups that they will cover, so that we could actually look at our pharmacy systems and say, which of our patients are in this insurance group, and then we can reach out to them and like, this is a covered benefit for you. And so it allows us to be more proactive and identify which patients that they will pay for. So whether that's test and treat or oral contraceptives, or it's not just, hey, do you want birth control? No, you might say you think you have strep or flu or something, but it allows them to know who their covered members are, and so that we can market to them. But yes, there's so many ways we can cross work with other groups to help market our program. And I'll just list some of those that have been really good supporters for us. One is just the Board of Pharmacy, and making sure that, that the pharmacy protocols and all those different things have to go through the board and be approved. And they've been a great partner on that. I also want to call out the birth control pharmacist, Sally Raffy. She's been a great partner, and they have a lot of resources for pharmacies, for payers, for patients. There's a lot of information there from her site, and she's been a great supporter and has really led the charge for years on this. And so a big thank you to her. Also, Blue Cross Blue Shield has been, a great partner, not just to get it started, but they really want to see it take off. And so we meet with them once a month on, because they can only see who's prescribed and ask for payment within their system. But then we also get data from the health department. So partnering with your health department, for us, I don't know why, but Arkansas pharmacists have to report their how many they've prescribed. So we do have that database. Now, other healthcare professionals don't have to do that, but so I guess it's kind of helpful for us to just to gauge the uptake. We also worked with the governor's office. They had a governor's maternal health. There were a number of different subcommittees, and all of our pharmacists on our staff were part of those committees. And the governor's and working through that, we worked with a lot of, the medical society and the nurses and the lots of different groups came together on that. So being a part of that initiative was very helpful, and getting pharmacy's message out there. And then your local colleges of pharmacy are very important training grounds for pharmacists, and also data collection and residency programs and all those different things are very helpful. And I already mentioned the CPSN network that is in most of the states. They're great partners, and they have their own communication systems and the coaching and payment systems and different things like that. So that's a great partner for each of the states to look at as well.
And Nikki, I'll just add real quick behind you. It's also been a great collaboration effort between pharmacists and providers, family care physicians or PCP, primary care physicians, and women health providers, because according to the legislation right now, we can only prescribe oral contraceptives. And if they haven't been seen by, a PCP or a women's healthcare provider in so many months, then we can do a limited supply of birth control pills. Or if they want a different form of contraception, then we have to refer them out. And so there's collaboration, between providers and pharmacists, which helps to strengthen these efforts.
And I'm gonna turn to Ryan in a moment to say a little more from the Apple Health perspective about collaborations across other stakeholders, the roles that HCA has played relative to other agencies and stakeholders. But before we move to that, I just want to highlight an issue that's come up for a couple of folks in the chat. So we've been talking a lot about Blue Cross Blue Shield in Arkansas because they really emerged as a leader in implementing and being proactive about working with pharmacists and pharmacies to be credentialed as providers and implementing training for and support for billing. But you did mention earlier that you've also been trying to expand this to other third-party payers. You mentioned that you're planning a payer conference. Could you say a little more about your efforts to move beyond that one early adopter?
For us, I mean, okay. Yeah, we're scheduling a payer conference. We've been at first, Blue Cross Blue Shield is the one that brought it up and said, yeah, we need to get more payers involved, because a rising tide floats all boats. And but they said, well, maybe we don't need to host it. Y'all can host it, and as the association, and they will certainly participate and encourage other people to join. But we're probably going to have a payer conference where we invite, the Centenes, the United Health, the Medicaid, the governor's office, and different people, but not have a big conference. Just get the decision makers on board and let them talk among themselves on. Sometimes they're afraid that it's going to cost us a whole lot of money to do this. Well, Blue Cross's experiences, they don't have lots and lots of people. The uptake has been a little bit slower than probably that some people anticipate. And so it hasn't been a big outlay of money. But what we hope to see is the savings dollars. We're paying less than we would for a physician prices. But mainly, what really opened the door for us was, when Roe versus Wade was shut down, then they needed to make sure that they weren't paying dollars for births instead of contraceptions. So we are hoping to get, the message of dollar savings out there as well. And it should make sense. It's just it's been, I think in time that will come to fruition, but we don't have, enough time and data to see that right now, but there should be a cost savings involved.
So I'd like to bring Washington back into the conversation again. Ryan, could you tell us a little more? You mentioned, or Andrea mentioned, WIC being, part of the conversation too, in raising awareness about availability of these resources. Can you say a little more about cross-agency collaboration? Sort of who are the decision makers that you've worked to get in the room and get on the same page?
The main one that we've been working with hasn't been another government agency. It's been with our pharmacy association. So similar to what you've heard in Arkansas, where their pharmacy association worked with the Blue Cross Blue Shield, we've been working with our pharmacy association. And so a lot of the information, that I've been talking about is available on the website. So, they are doing a good job of being connected to each of the individual pharmacies who are the impacted parties, and they can take the information from us and other payers in the state and help provide that in kind of a more succinct and appropriate form for their audience. So we've really worked with them. The only other government agencies that we've really been working with is our Department of Health, which is where the practice of pharmacy is regulated in the state, and trying to help with some of that public health. But really, it has just been with the State Pharmacy Association because they do such a fantastic job of working with the pharmacies and helping answer their questions and working with us as needed in case that there's something they can't answer.
That's really helpful. I think a common theme that came through in our work with both of these states and the many others that have been represented in our study who have implemented these laws, but they haven't been as robustly implemented in terms of access, is this sort of collaboration that needs to happen across payers, the retail pharmacies, the Pharmacists Association, to raise awareness and to remove some of the barriers that have been identified. I want to invite each of our three remaining panelists to share anything further about sort of how does one go about getting that started? How do you start those collaborations? I know from our work, part of the reason that Blue Cross Blue Shield emerged as a leader was that there were just key individuals there who made this a priority, who happened, based on their background and expertise, to know that this was an opportunity and to make the commitment to pursue it. Is there other advice that you would share with some of the advocates who might be listening to this discussion about, how do you get the ball rolling? What's the most important step to get these collaborations started?
Lindsay, I'll just say, and I'll be jumping off here in a minute, so I have a hard stop about in a couple minutes. But I would say it's just simply, just sometimes just opening your mouth and having a conversation, with people about what you're wanting to do, because you'll find out that, you know, people are have the same agenda or motive or want to provide some of the same services that you're doing. And so anytime that you have an opportunity to network, if you're attending meetings or what have you, legislators are a big, key to our success on this as well. But anytime you have an opportunity to build relationships or develop those relationships, sometimes it's just through a simple conversation, making those connections.
Nikki, anything to add for your advice?
I would say if for the states that don't have this are not allowed to prescribe birth control, I would say, then advocacy and legislative work is very important. I think your state association could, find a champion in the legislature to run these bills, and then having pharmacists have strong grassroots efforts where they know their legislators. They can say, yes, I can do this. We can step up. There's a need, and we can fill that need. One of the questions in the chat was like, why don't you put them in OBGYN offices? Well, I'm like, well, if they could get to an OBGYN, that would be great. But in Arkansas, there's hardly enough OBGYNs for 10 counties, let alone 75. So, what we're trying to do is increase access. And so when you can step in and say, there's a need, pharmacists can solve that need and talk to your legislator and get them to see that pharmacists can be a solution for the problem.
Yeah, and I think I have a similar kind of recommendation is to really find a champion, who can dedicate their time and resources, for this advocacy, because a lot of this work is being done by the state pharmacy associations. I mean, that's, kind of the key theme that I've heard between Arkansas and Washington. I imagine it's the same in other states, and just being able to use those resources to advance the profession forward. I think, and this isn't something that I can speak from experience, but I think student pharmacists, so at these different colleges of pharmacy, if you can get messaging to them and explain to them why this is important, this is the future of their profession that they're going into. And I think if you can get that messaging to them earlier, and even get them within the advocacy, I think that can spell success for these different types of initiatives. So in some of these other states where they may not have that, getting some of these student pharmacists on board can help, change the flow and move the profession in the right direction, for those states and for those communities. So although I can't speak for that here in Washington, I imagine that would be a great option for a lot of states.
I really appreciate those words of advice. I'll ask one last question, which came in early in the chat, but I've been saving it for the end for our two remaining panelists, which is the role of evaluation in all of this. The question in the chat was, what do we know about, in states in the, nearly half of states that have adopted these laws, what do we know about how many pharmacists are actively prescribing, how many consumers are taking advantage of this service? And my sense is that we're not really all the way there yet. We're currently in the mode of just identifying these barriers. We had this really excellent resource linked in the chat from University of Arkansas Medical Sciences, discussing with pharmacists about, are you doing this? What are the things that are keeping you from implementing this service? What is the timeline that you see, just as a closing comment? What is the timeline that you see? What would success look like long term when we get to the point where we feel like we've, removed some of those barriers and that we're ready to measure the success of these efforts?
Well, I can go back to, I remember when vaccines first came out as being in the pharmacist area that they could provide vaccines, and there was pushback. It took a while to happen. It took 20 years before it was, and it took COVID too. But there was just a number of barriers for that space too. Education. I don't know. I'm not used to handling all that. Now it's commonplace, and now most of the vaccines are provided in pharmacies. I don't think, you're going to get most of birth control necessarily in pharmacies, but it could be, because when you become an expert in that area and it's going to develop, and one of the things you have to pay for it. You can't just expect them to, oh yeah, we want you to spend 30 minutes with a patient, but we're not going to pay you for it. That's not, it's not feasible for that. So we have to, if it's important to us, we need to pay for it, and you get what you pay for. Pharmacists will be able to put the time and resources in if they're able to make it sustainable, and sustainable means getting paid for it. And if that happens, then I think we can definitely enter this space. We're experts on drugs. This doesn't involve a diagnosis. Somebody doesn't want to be pregnant, we can help them. It doesn't, we know the medications, we can help them get started. Because a lot of times, and we're not trying to take the place of a physician at all. And in fact, we refer to them to make sure not only do you need maybe get birth control before you can get in to see a physician, but then, yes, then tell them it's important to get, to pap smears and, other services that we don't provide in the pharmacy. And, they pay us for a consult even if we don't fill a prescription, because we can say, no, this birth control is not the best answer for you. But just spending that time with them and get them to be seen and get the appropriate products or services, then that's important too. And so we work together with the healthcare team and hopefully have a good relationship. I'm going to send you this patient, and she needs to be seen for this service. And maybe when they said, oh, I can't see you in the office, but you can go to your pharmacy in the meantime. So I think we need to work together as a team to make sure women, one of the things that was really kind of disturbing to me is of women of childbearing age in Arkansas, only 20-something%, less than 30% for sure, are using any form of contraception. And that's staggering to me. And that's going to affect, so much of their life if half of the pregnancies in the United States are unplanned, and we need to help give them better choices.
Thank you for that, Nikki. Ryan, you get the last word on the role of evaluation. Where do you see this heading on what kind of time frame?
Yeah, I mean that's a great point. So I'd helped put a map in the chat, which I see has been posted to everyone. So before I knew about the birthcontrolpharmacies.com, I had found on our State Pharmacy Association a map that shows what pharmacists are currently able to do the hormonal contraception. And so I think for us, success really is seeing that map expanded. It does touch in a lot of the most populated parts of the state, but you do see that there are some of these deserts, especially in Eastern Washington, and kind of in rural Western Washington. So I think, for us, success would be a wider adoption of that. And I think one of the ways to get to that wider adoption is for pharmacists to get reimbursed, through Medicaid. So I think we would be happy to see those bills that are in Congress pass. So then that way Medicare and Medicaid can recognize pharmacists as providers, and they can bill for their healthcare services, and actually have more of an incentive, given that, for our Apple Health population is about 2 million Washingtonians. Our state is about 8 million total. So that's, 25%. We do have a very significant portion of the, women in childbearing age. And so I think that that really is the biggest barrier. And so success is seeing, that federal legislation change, allowing states to be able to reimburse for those services. And that, I think, would encourage a lot more of these providers, especially in rural settings, to take that up as an additional service, plus all of the other things that are listed on that map. So that map is just not only for hormonal contraception. There's the tobacco cessation, the TB testing, the naloxone. So all of these other services that pharmacists can provide beyond just this, and really expand the profession of pharmacy to be, recognized for who they are and what they can do.
Thank you so much to our panelists for making time in your busy schedules to share your insights, your expertise, your experiences in Washington and Arkansas. And thank you to all of you for joining us as attendees as well.
Thank you.
Great. Thank you.